Hello everyone, welcome to my channel EduHub.2m. Today I am going to discuss about hemolytic anemia, a detailed overview when we are going to know about the pathophysiology, diagnosis and management of conditions characterized by abnormal red cell destructions. So that much we know from this topic that we are going to discuss about an anemia, the reason of which is abnormal red blood cell destruction. So what is hemolytic anemia? It is characterized by the premature destruction of red blood cell. What is the premature destruction? That means all we know that the normal lifespan of a mature RBC is 120 days. This accelerated breakdown called hemolysis occurs either within the blood vessels, that is intravascular, or in the reticular endothelial system, primarily the spleen, that is called extravascular. So when the red blood cells are destructed before 120 days of lifespan, with the condition which is known as hemolysis, then the anemia, hemolytic anemia occurs. So when we are classifying hemolytic anemia, we can say that it can be of two types: intravascular, when it occurs within the blood vessels. That means when before 120 days of lifespan, the red blood cell are destructed within the blood vessel, and number two, when they are destructed extravascularly, like in the spleen. Regarding the epidemiology, it is 5% of all the anemias. It represents 5% of all anemia cases worldwide. There are other types of anemia as written here, that is iron deficiency and megaloblastic anemia. It is less common. 400 million people affected globally. They carry the gene for the hemoglobinopathy and can cause the hemolytic anemia. So hemolytic anemia also comes under the hemoglobinopathy, means a problem which is connected with the problem in the hemoglobin. 7.5% of African population are affected by this hemolytic anemia. G6PD deficiency. Now, what is the full form of G6PD? Glucose 6-phosphate dehydrogenase. It affects the 7.5% of the global population with higher prevalence in Africa, Mediterranean and Southeast Asia. So, due to the G6PD deficiency, in Africa, Mediterranean and Southeast Asia, 7.5% people are affected with hemolytic anemia. To understand the hemolytic anemia, we have to understand the life cycle of the RBC and the normal turnover. So the normal life cycle of the RBC is divided into 4 parts. Number 1 is the production of the RBC. We all know that the production of the RBC is known as erythropoiesis, which actually happens in the bone marrow. In case of adult human being, it happens in the red bone marrow, and it is stimulated by erythropoietin. It's a particular substance which is produced in the kidney. After production, it goes to the circulation. Part 2 is circulation, where mature RBC enter in the circulation and transport oxygen for approximately 120 days. So this 120 days are the total lifespan of a mature RBC in the circulation. The third step coming, removal. Now the aged RBCs are recognized and removed by macrophages in the spleen and the liver. Now, what are the macrophages? Macrophages are some specific parts which are microorganisms which are present in the spleen and the liver, which actually helps in the destruction of the dead RBC. Not only the dead RBC, or the dead cells of our body are removed by these macrophages. And the fourth part is the recycling. Recycling means iron is recycled for new RBC production because it cannot be wasted. We receive iron only from the dietary source, and heme is converted to bilirubin. So the recycling part is two. Number 1 is iron is recycled for new RBC production, and heme is converted to bilirubin. So these 4 parts are the normal life cycle and normal turnover of a mature RBC: production, circulation, removal, and recycling. Now, the pathophysiology of hemolysis. Before two slides, we have discussed about the intravascular hemolysis and extravascular hemolysis. What is intravascular hemolysis? Once directly within the blood vessels, often due to a complement-mediated lysis. Lysis means breakdown, mechanical trauma, or severe oxidative stress. What happens when there is intravascular hemolysis occur? Number one, free hemoglobin released into the plasma. Naturally, when the hemoglobin breaks down, hemoglobin will be free coming out from the RBC. Now, they binds to haptoglobin, which becomes depleted. So, free hemoglobin binds with the haptoglobin. Now, excess hemoglobin filtered by the kidney, potentially causing hemoglobinuria, means they will pass through the kidney, they will appear in the urine, and this condition is called hemoglobinuria. So these three things happen in intravascular hemolysis. So first of all, free hemoglobin released into the plasma, they binded with the haptoglobin, excess hemoglobin passed through the kidney and appears in the urine, the condition known as hemoglobinuria. Now, during the extravascular hemolysis, often due to antibody coating or intrinsic RBC defects, leads to increased bilirubin production, result in jaundice and risk in gallstone formation. So extravascular hemolysis, as we know, the RBCs are destroyed by the macrophages of the reticuloendothelial system, which contains two vital organs of our body. One is spleen, another one is liver. So this is the classification of hemolytic anemia. Initial classification is divided into primary causes of hemolysis depending upon the cause. Cause number one, intrinsic, where RBC is destroyed within the blood vessel. Extrinsic, in external factors attacking the normal RBC. So the first classification or the initial classification depending upon the primary cause. The cause may be lying within the RBC or it may be lying outside the RBC. Next, the intrinsic causes, further classified by the type of the RBC defect. Number one, membrane disorder. Means probably the membranes of the RBCs are not formed or morphologically not sound. They are not capable enough to cover the RBC properly, or there may not be enough antibody present on the outer surface of the RBC membrane. Number two, enzyme deficiencies. Just we have crossed about this information that glucose 6-phosphate dehydrogenase deficiency, which causes 7.5% of the African population to become affected with hemolytic anemia. And hemoglobinopathies means if there is any problem in the morphological stature of the hemoglobin, which might be genetic. Now, extrinsic causes categorized by mechanism. Immune mediated, where the immune system of the body provoked in the lysis of the RBC and causes the hemolytic anemia. Mechanical, some extra pressure from the outside. Infections, if the body is infected by various microorganisms, then also hemolytic anemia can occur. Chemical or drug induced, it can also be caused by the side effect of some drugs which is taken by the person for any cause, for say any disease. Now, regarding the intrinsic causes of RBC abnormalities, there are basically three causes. Just we came across the previous slide. Membrane defects, enzyme deficiency, and hemoglobinopathy. Regarding the membrane defect, hereditary spherocytosis and elliptocytosis, you should remember these two terms, this spherocytosis and elliptocytosis. They result from mutations in the membrane proteins, spectrin, ankyrin, and band 3. So this spherocytosis, elliptocytosis, these two are the main outcome of the membrane defects, and both are hereditary in nature. That means it comes from one generation to another generation. And what happens there? There happens the mutation of membrane proteins which are present, the membrane which is present in the outside of RBC, which actually covers the RBC. Now, what are the proteins which are in problem? Spectrin, ankyrin, and band 3. The abnormal membrane leads to altered RBC shape. Naturally, if the membrane morphology is not good, then the normal feature of the RBC will also not appear. Reduced deformability and premature splenic destruction. Next. Number 2 is enzyme deficiency. So G6PD deficiency, glucose 6-phosphate dehydrogenase. It is an X-linked deficiency, means it's also genetical. And this pyruvate kinase deficiency impair RBC metabolism and protection against oxidative stress. So this pyruvate kinase deficiency, it impairs the RBC metabolism. That means the production, the maturation, and the destruction of the RBC. It is dependent somehow on this glucose 6PD, glucose 6-phosphate dehydrogenase. G6PD deficiency affects over 400 million people worldwide. We have crossed through this information. Next, hemoglobinopathies. So sickle cell disease and thalassemias, they involve the abnormal hemoglobin structure or production. Just remember, abnormal hemoglobin structure or production. So it might be due to the structural problem of the hemoglobin or the production or the volume of the hemoglobin. This genetic disorder causes chronic hemolysis and most prevalent in region historically affected by malaria. So this hemoglobinopathy is directly affected by or totally associated with the malaria. So 3 intrinsic causes should be remembered. Number 1 is this membrane defects, which is due to the mutation of some membrane proteins like spectrin, ankyrin, and band 3. Enzyme defects, the one and only enzyme is G6PD, glomerular 6-phosphate dehydrogenase, and it is an X-linked problem. Next, hemoglobinopathies, where in sickle cell anemia and the thalassemia, there is abnormal hemoglobin structure which leads to destruction of the RBC, that is hemolysis. Now, extrinsic causes or environmental factors. Number 1, immune-mediated hemolysis. What is that? Autoimmune hemolytic anemia, AIHA, warm antibody or cold antibody. So this is due to this IgG and IgM, immunoglobulin G or immunoglobulin M. Now, alloimmune, transfusion reaction, hemolytic disease of the newborn. So it can happen in the newborn also if there is any immune-mediated problem, or during transfusion, if there is any immunological problem, then also this type of problem in hemolytic anemia can happen. Then drug-induced immune hemolysis. If there is any drug which is not suitable for the body, this can also cause the hemolytic anemia. So there are 3 main reasons for immune-mediated hemolysis. Next, mechanical hemolysis. And what is that? Mechanical hemolysis. That is prosthetic heart valves. If the heart valves are not okay, if it is not natural, it is somehow disturbed and it is replaced, so there this problem can happen. Then microangioplastic hemolytic anemia, TTP-HUS-DIC. This is very important. It also happens in severe patients. Then March hemoglobinuria, where the hemoglobin comes directly into the urine because the kidney directly filters the excess amount of hemoglobin from the circulation. Next, infectious causes. Number 1 is malaria, direct parasitic invasion of the RBC. Next, Clostridium, that produces alpha toxin in the body. Then babesiosis and Bartonellosis. So these are the infectious causes which directly affect the RBC, and the RBC breaks down, which is called hemolysis, and the hemolytic anemia occurs. Then chemical and drug induced. Oxidative agents like sulfur drug, then direct toxins like lead, copper, snake venoms, hypersplenism, increased splenic sequestrations means if the spleen is working faster or more than the normal activity, then also this happens. So there are four extrinsic causes for the hemolytic anemia. One is immune mediated hemolysis where the immune system is broken down. Then mechanical hemolysis where some prosthetic heart valve is used or some micro organopathic hemolytic problem is there or hemoglobinuria is there. Infectious causes, first of all malaria and other problems of the toxins which directly affect the RBC, and chemical or drug induced. There are different types of drugs which are not supportive for the RBC that also can cause hemolytic anemia. Now, what are the key symptoms and the clinical features of hemolytic anemia? So there will be general anemia symptoms that the patient there will be fatigue, weakness, pallor. Pallor means normal color of the RBC will be fade down. Then shortness of breath means respiratory troubles and tachycardia. Tachycardia means increased heart rate when heart is forced to beat faster to deliver oxygen to different parts of our body. Next, hemolysis specific manifestation means what the symptoms we will find other than the general anemic symptoms like jaundice. Then a yellow vein of the skin or sclera occurs due to the increased bilirubin from RBC breakdown. Dark tea-colored urine results from hemoglobinuria in intravascular hemolysis. Splenomegaly is common. So there are three main things which should be remembered which can be seen in the body of the patient suffering specifically from the hemolytic anemia. Number one is jaundice, that means yellowing skin or sclera. Number two is dark tea colored urine, which is called hemoglobinuria. And number three is splenomegaly, common, that the enlargement of the spleen. So these three are the specific symptoms which specifically can be seen in the patient suffering from hemolytic anemia. Number one, jaundice. Number two, hemoglobinuria. Number three, splenomegaly. Next, acute versus chronic presentation. Acute hemolytic episode may present with fever, chills, back abdominal pain and even shock in severe cases. But chronic complications like gallstone, leg ulcer means it's much more severe than the acute. So regarding the complication and long-term risk, we can see that gallstone risk is 30%, pulmonary hypertension is 15%, and iron overload is 70%. Now, what is this gallstone risk? Chronic hemolysis leads to, so chronic hemolysis, not the acute one, leads to increased bilirubin production and excretion, resulting in pigment gallstone in approximately 30% of the patient. Means when there is huge amount of bilirubin is produced during hemolysis, then where this extra bilirubin will go, it will create a problem and it will form the gallstone. So the risk is in case of 30% of patients. Now regarding pulmonary hypertension, free hemoglobin scavenges nitric oxide causing vascular dysfunction. Up to 15% of the patient with chronic hemolysis anemia develop pulmonary hypertension, means there is less amount of hemoglobin, so high amount of demand for oxygen is not fulfilled by less amount of hemoglobin, so there will be a tension in the respiratory system, which is pulmonary hypertension. The risk is 15%. Now, the maximum problem occurs in iron overload, which is 70% risk. Approximately 70% of regularly transfused patients, remember this, means the person who have undergone blood transfusion for hemolytic anemia, develop iron overload within 10 years, risking cardiac, hepatic and endocrine dysfunction without chelation therapy. Means when there is iron overload, what will happen? The cardiovascular system, the liver system and the endocrine system will get gradually damaged. So This problem occurs within the 10 years of this transfusion, regular transfusion therapy. But if there is occasional transfusion for the hemolytic anemia, maybe there is not so much problem. That is, it may not be 70%, might be 35 to 40%. Now, what should be the diagnostic approach? What is the history and the physical examination? So, what history should be taken? Number one, family history of anemia, jaundice, splenomegaly, or gallstone. Means if there is a tendency in the family of suffering frequently anemia, then jaundice, then their splenectomy, there is no spleen, means some part of the spleen is removed due to any reason, or the gallstone problem, then the offspring might be face the trouble of hemolytic anemia. Next, medication therapy, recent new drugs, antimalarials, antibiotics. So this may cause problem. Medical history, then transfusion history, if there is any previous reaction occurred, then symptoms pattern, acute or chronic, or the something that triggers this hemolytic anemia, that means hemolysis. Then travel history, if the person travels into the malaria endemic zones, and if there is a bite of mosquito which caused a malaria, then there can be the every possibility of hemolytic anemia. So comprehensive history should be taken to diagnose properly if there is any possibility of hemolytic anemia for a particular person. Now, what physical examinations can be done? So, vital signs like tachycardia, hypotension in severe cases, trachycardia, hypotension in severe cases, that are the vital signs that should be noticed. Then, skin and mucous membranes pallor, jaundice means the color will be changed. Abdominal exam, then splenomegaly, hepatomegaly means splenomegaly means if the spleen is enlarged, hepatomegaly if the liver is enlarged. Then cardiovascular flow murmurs means there will be a continuous sound when the blood will flow through the blood vessel. Evidence of underlying disorders like lymphadenopathy and joint abnormalities, sign of complications like leg ulcers, etc. So these are the physical examinations that should be done to become confirmed that if the person is suffering from hemolytic anemia. What are the key laboratory tests that should be done to identify whether the person is suffering from hemolytic anemia or not? Number one is CBC, or complete blood count. Anemia with reticulocytosis means elevated reticulocyte count. It confirms anemia and shows bone marrow compensation. That means there is a problem in the bone marrow also. Haptoglobin test means where the haptoglobin, the amount of haptoglobin will be determined. It will either decrease or there will be totally absence. So sensitive marker of intravascular hemolysis. So if the haptoglobin is found to be decreased in value or absent, that means there might be a problem of intravascular hemolysis. Lactate dehydrogenase or LDH test, if it is elevated, it means released from damaged RBC. It indicates the cell lysis. Means this LDH is present within the RBC. Now, if it is elevated in the normal blood, that means that there is lysis and from RBC it came out. Bilirubin, elevated indirect unconjugated fraction result in increased RBC breakdown. We have discussed it just before. Direct antiglobulin test or DAT test. Is it positive, or if it is positive in immune mediated hemolysis, it detects the antibodies or complement on RBC surface. As I told earlier that the antibodies are totally distributed out on the outer structure of the RBC. Peripheral blood smear, RBC morphology abnormalities may suggest specific diagnosis. See the next slide for that. So these are the laboratory tests which have to be done to become confirmed that the person is suffering from hemolytic anemia, and what are the underlying causes of that, what it indicates actually. So this is the peripheral smear findings. Means if we make a smear and if we look at the smear, what we will find? Cystocytes means this fragment look like this. These fragmented RBCs are hallmarks of microgeopathic hemolytic anemias like TTP, HUS, and DIC. They form when RBCs are mechanically shed while passing through damaged microvascular. So when the RBCs are flowing through microvascular, then due to some pressure, they are broken down, and these fragmented RBCs are known as cystocytes. Now, spherocytes, see, the RBCs are round in nature. Here, RBCs are broken down in nature. So, spherocytes, dense spherical RBCs without central pallor, That means there is no space for hemoglobin color, characteristic of hereditary spherocytosis, and warm autoimmune hemolytic anemia, means IgG, if you remember that slide. Next, reticulocytes, immature RBCs released prematurely in the bone marrow in response to anemia. So, in peripheral blood smear, we will find cystocytes, which are fragmented RBC, spherocytes, which are rounded RBC, and reticulocytes, which are immature RBC. So regarding the additional specific diagnostic test, that is specialized laboratory test, there will be enzyme assay like G6PD, glucose 6-phosphate dehydrogenase, and pyruvate kinase activity levels. That means if they are really active within the RBC. Next, hemoglobin electrophoresis, which will identify hemoglobinopathy if there is any morphological trouble within the hemoglobin. Osmotic fragility test actually done to know the fragility of the RBC membrane or membrane disorders, we can say. Then cold agglutinin, then PNH with the help of the flow cytometry. Then genetic testing for hereditary conditions. Now, imaging and additional studies. Abdominal ultrasound to know about the splenomegaly, that means the spleen size and the presence of the gallstone. Then bone marrow examination, whether the bone marrows are good, functional. Iron studies to assess the iron overload. Urine analysis for hemoglobinuria and hemosideриnuria, means if the hemoglobin or hemosiderin are present in the urine. Infectious disease testing like malaria smears, which requires the thick peripheral blood smear. Then viral serology for the presence of the virus and other microorganisms, etc. Then autoimmune panel for underlying the autoimmune disorder. So apart from the normal diagnostic tests, there are some specialized laboratory tests and imaging and additional studies also to identify hemolytic anemia. So what should be the management principle? We have to address the underlying cause, that whether it is intravascular, what is the cause, intravascular cause or extravascular cause. Then supportive measures we have to give, specific therapies we have to give, then managing the complications. So management begins with identifying and treating the underlying cause, discontinuing culprit medications, treating infections, and managing the autoimmune disorders and all. Regarding the prognosis and outcomes, hereditary forms, typically lifelong conditions requiring ongoing management but with good long-term survival, like a specific genetic defect and its severity, we have to identify all this. Response to intravenous interventions like splenectomy, then adherence to the prevalence measures, then development of the complications. We have to monitor all this and we have to do accordingly with planning. Acquired forms, if the problem is hereditary. If the problem is acquired, then if it is drug induced, then we have to remove the trigger. Autoimmune 70 to 80% respond to first line therapy. Then microangiopathic means depends on underlying conditions, and infections generally good with treatment. So these are the acquired forms. Regarding the advances and ongoing research, novel therapeutics are there. Complement inhibitors are used for PNH and cold agglutinin disease. So there is gene therapy for identifying the gene for the hemoglobinopathies like sickle cell anemia and beta thalassemia. Then diagnostic advancements are there. if these are not at all pocket friendly, but still people can use that, people can go for that. So the summary of this total presentation. So what are the clinical approach towards hemolytic anemia? Recognize the hallmark triad, means there will be anemia, there will be hemolysis and compensatory reticulocytosis. So hemolytic anemia or hemolytic anemia is equal to symptoms of anemia plus evidence of hemolysis plus compensatory reticulocytosis. Next, we have to classify it whether it is intrinsic or extrinsic depending upon the history, examination and laboratory findings. Number 3, we have to distinguish between acute and chronic presentation for appropriate management, because the acute hemolytic anemia and the chronic hemolytic anemia symptoms are not same, so their treatment will be not same. Consider the hemolytic anemia in patients with unexplained jaundice or splenomegaly, means if a person have no problem or no report of anemia, but still there is a problem of jaundice and splenomegaly, then we have to think that if this person is suffering from jaundice or splenomegaly, which are the result of hemolytic anemia. So this should be the clinical approach. How they should be managed: tailored therapy or specific underlying cause, balance benefit of treatment against potential risk, monitor for and prevent long-term complications, consider genetic counseling for hereditary forms, it's very important, stay informed about emerging therapeutic options. So, hemolytic anemia encompasses diverse condition with potentially severe manifestations. So we have to think about hemolytic anemia, its details and management. So thank you for your patient listening. Don't forget to like, share, subscribe my channel. Name of the channel is eduhub.today, where every day I try to post new educational videos related to graduate, postgraduate, medical and paramedical students, not only on hematology but also on nutrition, statistics, education, etc. Thank you very much. And this is not the end of the post. I will again post on different topics of hematology, like definition, morphological types and diagnosis of anemia, then polycythemia, then leukemia disorders, so that this applied pathology series goes on, and all the students who are record in their syllabus this applied pathology can see this channel. Please share with your friends and other students so they can also get benefit of my channel. Thank you again.